Welcome to NAS 2025 from Denver, Colorado. We'll be talking about the second portion about training and its duration. Is it too long or too short? My name is Thomas Wozny. I'm a neurosurgery spine fellow.
I'm William Chu Kwan. I'm an orthopedic surgeon from Vancouver, Canada.
I'm Darius Ansari. I'm a neurosurgery trainee in Madison, Wisconsin.
Yeah, great. So I can toss it up to the group if anyone wants to tackle it first. Too long, too short?
So I guess it also depends on people's background. I would say as someone that finished orthopedic surgery and going in spine surgery, there is a lot of redundancy that would say. Like I appreciated my rotations in foot and ankle, for example. However, spending 6 months in foot and ankle brought me skills like finesse, for example. However, how applicable is it those 6 months to spine surgery itself? Well, I could have dedicated 6 months concentrated on spine surgery. So I think, and maybe I'm biased, in the orthopedic surgery world, spine surgery occupies not a significant portion, unfortunately. Therefore, I would have liked to be a little bit more specialized at the start of my training, so including like first or second year being exposed to spine, and then increasing more and more my exposure throughout, so I wouldn't have to spend that much time feeling that I had to catch up and feeling that I had to spend a lot of time in other aspects of the body when I knew I needed to do spine surgery. Although I would say the counter argument is that that has brought me a breadth of knowledge that would help me on my clinical day-to-day. But it's just something that I have debated for time. How about you, Darius?
Yeah, I think similarly, as someone training in neurosurgery, I kind of agree. As similar to the orthopedics, we have such a wide breadth of training and kind of mastery that we need to have as neurosurgeons. And so I'm talking things like not just spine, but endovascular, tumors, skull base, open vascular, pediatrics, functional. There's so many different aspects of it that as trainees, it's a 7-year program for us in neurosurgery. And it's easy to kind of look at that and say, hey, it's a lot of time. That's, we already done so much school. That's a lot of your life to dedicate to it. But really, I think to some degree, a lot of that's necessary to truly kind of, make sure you've gotten a good assessment of what each field entails. I think that one thing that's important when considering the length of the training is not just the length of the training itself, but how well you can focus your time within that training. Like you had kind of said, if you had known earlier on that you want to work to train in spine, that if you could tailor that your experience, the rest of your experience to that, that's a lot different than someone who's locked into doing mostly general training and doesn't have much fluidity. So I would say that there's a lot of drawbacks and benefits to being painted with a broad stroke at the beginning and being exposed to many different types of fields. But 7 years is a long time. How much is that? How much is that worth it? I don't know.
Yeah. So it sounds like there's a kind of a general consensus or idea brought up here that training in a way is for a generalist covering all these areas,
Right.
but ultimately people are practicing in a much more specialized way.
Yeah.
And so while that is a nice, broadening of your knowledge base, perhaps not the most applicable when it comes to actual practice down the road.
I mean, but this was before all of our times, but at one point we neurosurgeons used to train in general surgery for a year, an internship, and then it became more specialized later on. There's kind of this trade-off of, at some point, when do we become so subspecialized in medicine that maybe one day, maybe there's talks of a spine surgery residency. When do we? I know orthopedics fellowships-wise is also pretty subspecialized, similar to neurosurgery.
Yeah.
So I think it's tough. We have to balance being able to be generalists, like we were talking about, but at some point, I think as the tools in endovascular neurosurgery become so sophisticated, or in spine, for example, I think there's going to be more and more talks of focusing that training in earlier and earlier.
So the thing is that focusing the training on is really good if you know from the get-go that you want to be a spine surgeon.
Yeah,
but
very
someone that comes in, I just want to be a surgeon, like, and I remember in med school, which was many years ago, you go and try different specialties, right? So then I was okay, I'm going to be a spine surgeon. And then after trying different like subspecialties inside spine surgery during my first couple of years, I landed on spine surgery like in the middle towards the end, right? Sometimes I wonder if spine surgery would have been one of the options that you needed to decide in med school. Would a lot of spine surgeons be spine surgeons today? Because they didn't have the time to develop the skills, develop the confidence, develop just the mindset to be able to tackle those tasks.
Yeah.
So it's just something to consider.
Yeah.
Yeah.
Yeah, I think the idea that was brought up before about potentially 2 stages even within a residency, one that's more general and one later in residency that allows you to kind of pursue these more specialized interests, I think is a really compelling idea. And I would also kind of insert into the discussion not just duration, because I think in this discussion makes residency training or spine training in general this kind of monolithic idea, right? And not very customized to the individual, including relatively limited options for evaluation, proving competency, and allowing you to move on. In some ways, once you get into residency, barring any disasters, you're kind of going to finish residency, and we're all going to finish it at the same time.
I'm glad you actually brought this point. So interestingly, the training model that I came from is called competency by design. And the way it is in orthopedic surgery, it's a little bit more subspecialized in the sense that at the first day of your PGY1 year in orthopedic surgery, you start in your knee rotation, right? In the knee rotation, all you do is to learn how to do a total knee replacement. You spend 3 months doing that. There was a midterm and a final that was both oral, written, and also procedural. So if you pass that check mark, you're able to achieve all the goals for that stage, then you move on to your rotation. And the idea was that given this competency by design, once you hit all the check marks for a generalist orthopedic surgeon, you're able to move into your subspecialist checklist. So if someone is able to go through all of those in 2/3 of the time, then they can spend the other 1/3 just working on whatever they want to do.
That's fantastic.
Yeah, but it does require a whole change on the mindset of how the educational system is, and it's very resource intensive, because that would mean all your preceptors, everyone would be actually sitting with you, evaluating you every 6 weeks. And as a trainee, I remember it could be a little bit of anxiety inducing, because not only do you have all your clinical duties, but you needed to study, and you needed to hit those marks in order to, one, pass the rotation, and if you excel, maybe shorten your program.
Yeah, that's a very different model. I think some of the value in having these conversations, bringing in more perspectives, ortho, neuro, outside of the US.
Yeah.
Yeah,
It's
I mean, that's fantastic.
Yeah,
I would have loved to go through that.
Well,
But maybe it's easy to say having not done it.
I don't know. There's the jury's still out there. Yeah.
But maybe I would have taken longer, though. Who knows?
Who knows? No, I doubt you wouldn't have taken longer.
Yeah.
Yeah, but so in Canada, at least, a lot of the programs are moving towards that model. Although I would have to also say that model is really hard to implement, because it's based on a volume, right? So you cannot have in the orthopedic world, for example, if you don't have a lot of patients that need a total hip replacement in your center, then how are you able to achieve those volumes to do that? So the implementation is quite tricky, to be honest.
Yeah.
Yeah.
Opens up a whole new can of worms.
Exactly.
Yeah.
Exactly.
This discussion of all the competencies, milestones, everything like that was structured into your training, it makes me think about something related to just the length of training in general, in that, naturally, if somebody asks the question, is training too long? That begs the question, is training long enough? Where do you draw the line of where somebody's experience has kind of allowed them to practice as safe and effective surgeons? Especially because, at you can do all this learning in residency and fellowship as we all do, but I feel like if you talk to any staff or attending, they'll all tell you that a lot of their learning was done their first couple years on the job, or they're still learning, you know, so. I think that I'm in no way am I saying that training is too long, but I do think it's important to consider that in any of these discussions of, you know, graduated autonomy, milestone reaching, how the length of training is that a lot of the training is, a lot of training is geared towards making us safe and effective surgeons, whether that's orthopedics or neurosurgery or general surgery. But with the understanding that the field is changing, you may work in different places in areas that you did not train specifically towards. That all requires you to be fluid and able to develop those skills as an attending. So I think that's pretty important to keep in mind when we talk about length of training and so forth.
Yeah. And one of the things is to say, when are we actually ready? Because I feel like in residency and in fellowship, there's always a safety net, right? And it's once that you're an attending at whatever time the training is, you remove that safety net, and that is when you have to make the decisions yourself.
You're all liable.
And you're liable for that. You are the one that actually sees the patient in follow-up, like week after week after week, right? And how do we assess who is ready for that, and when are we ready for that?
Yeah, I think that's something that we may never have a good metric for.
Yeah, that's true. This is just me saying words. Okay.
Well, yeah, I think probably the most universal opinion of anyone who's gone through, you know, medical training is that they really wish they would have spent more time in organic chemistry.
Correct.
But I think like we also, like a lot of people say, like we wish we spend more time with family because training is very long, right?
Yeah.
And it's the people around us that are also affected by our training. So that's just something that it is more and more in the discussion nowadays.
Yeah, I think it's a wonderful thought to maybe end it on.
Yeah, absolutely.
And so with that, thank you for watching, and we'll conclude there.